basically, welcome back. This next lecture is going to be kind of a review over a lot of stuff that we've already covered. You will notice, bear with me, a lot of this stuff we're going to fly right through. I did kind of pilfer this particular PowerPoint from the people over at Pearson VUE. But I did add some stuff to it. And basically what this is going to be is a real brief overview of some stuff and how we're going to correlate a lot of it into our actual practice out in the field. So we're going to look at some different cardiac emergencies and talk about the treatment of them. And then it'll be a little bit difficult due to the fact that we haven't talked really much about 12 lead findings in acute coronary syndrome and stuff like that. But that is next, so this will give us a good foundation whenever we get into that. So the first thing we're going to do is go over some of our coronary cardiac anatomy and physiology. And there's a couple other things that we're also going to be covering. We'll be talking about angina and pericardial tamponade. Okay, so again, real brief overview, coronary anatomy and physiology. We're going to talk about it. Here's a blank slide. Don't worry about it. So, coronary AEMT, like you guys we've already discussed, numerous times. Blood goes in the right atrium after coming in from the superior and inferior vena cava. It's pumped into the right ventricle, where it's pumped into the lungs. It comes back. It goes in the lungs via the pulmonary arteries. It comes back through the pulmonary veins into the left atria. It goes down in the left ventricle and it's pumped out in the body through the aorta. In a nutshell, the path of blood through the body. Obviously, this is important. My teaching notes here to make sure that I remind you that when the pump fails, it is bad. So, obviously, you guys know that. The 4 chambers from the heart, you guys know what those do. Just discussed it. Picture of our coronary conduction system that you guys should be quite well versed in at this point. SA node down into the interatrial pathways. Our AV node into the bundle of His, our bundle branches, and our right ventricle, our Purkinje fibers. All right. So here we have a example of a blood vessel. According to the state of Kansas, I am supposed to discuss with you guys what happens down in the capillary beds here. So as you guys probably remember from EMT class, you know the functions of the blood to carry, red and white blood cells, platelets, plasma. Remember that the veins, they break down into smaller venules, into capillaries. The arteries go to arterioles and into the capillaries. These combine all throughout the body. This is where the actual gas exchange occurs, where byproducts are removed from the blood and go into the veins, and where that oxygenated blood goes into the tissue. So, kind of hard for me to discuss this with you guys in relation to the function of the heart and our blood, our blood pressure. So, I'll just say that I'll give you the Lucas Martin definition here in this next question, how shock is related to the function of the heart and blood vessels. Basically, you'll hear shock defined in a lot of ways. A good way to remember shock is cellular ill perfusion. So whenever we have end cells that are not being adequately perfused, we're in a shock state. We're in a compromised state. Anytime there's a malfunction of the blood, of the, including a loss of blood. There's a malfunction of the heart. We have an issue with our blood vessels. We can create a shock state. So we're going to look at some causes of cardiac problems. We'll talk, let's see here. Causes of cardiac problems include heart defects that you're born with, congenital heart defects, 5 extra points. Anybody that give me a paper on tetralogy of Fallot, which is a congenital heart defect. High blood pressure is a cause of cardiac problems, diabetes, smoking, excessive alcohol use and caffeine, drug abuse, stress, valvular heart disease, and genetic predisposition. All causes of heart problems. Incidence of heart disease. There's 600,000 deaths every year in the U.S. From heart problems. That's 1 in every 4 deaths. The cost of heart disease is $109 billion annually. There is 720,000 heart attacks every year in the United States. That being said, let's start talking about it. Acute coronary syndrome. Known as cardiac compromise, refers to any time the heart is not getting enough oxygen. Many different kinds of problems under the heading of acute coronary syndrome. Acute coronary syndrome can commonly mimic non-cardiac conditions. Anytime you have somebody with ACS-like signs and symptoms, you should be treating them as though they have a heart problem. It is, not our job to rule out coronary problems. We aren't able to do that without lab work. We can go part of the way, but we can't go the full way and ruling that stuff out. So, symptoms of cardiac problems. Chest pain is obviously the best known symptom. Can be described as dull, crushing, heavy, or squeezing. Sometimes it can just be described as a pressure, and it often radiates to the arms, upper abdomen, and jaw. Dyspnea, also found in ACS, may be the only finding in some patients. So you think about the patients with non-typical cardiac symptoms, especially in diabetic females. They may not even have any chest pain. Other signs that you can see: anxiety, a feeling of impending doom, nausea, pain and discomfort in the upper abdomen, sweating when it's not appropriate to be sweating, an abnormal pulse or abnormal blood pressure. So you guys know, on all our patients, we're going to be performing our primary assessment, physical exam, etc. Our treatment. Place patient in position of comfort. Apply high concentration O2 and transport. Yeah, we're going to be doing some more stuff than that. We are going to be talking about 12-lead electrocardiograms and interpreting those. So nitroglycerin indicated for chest pain. It's often prescribed to people with cardiac problems. We can administer nitro to people with chest pain. You guys are AEMTs, so this is a common medication to be given. Contraindications for administering nitro are systolic blood pressure less than 90 or 100, depending on what your local protocol is, and patients that have taken erectile dysfunction medications within 48 to 72 hours. The dose of nitro is 0.4 milligrams sublingual, repeated. Generally, sometimes it's depending on your protocol, repeated 3 times. Up to 3 times, or you can keep giving it till you have, as long as you're hemodynamically stable. So aspirin's another treatment that we're going to be doing for chest pain. Contraindications for aspirin: inability to swallow, allergy to aspirin, history of asthma. Not really. Really, the only contraindication is the patient is allergic to it. So where do we transport our patients with acute coronary syndromes? As I'm sitting here, I don't know any of you guys, so I really don't know where you're going to be working at or what your plans are. I will say, since I'm working in Butler County today, that I'll talk about Butler County's protocols. Whenever we transport these patients, it's always best to take them to a PCI capable facility, which is percutaneous coronary intervention, or the cath lab. We do want to take these patients somewhere appropriate that can handle them, and that's going to be Kansas Medical Center for us. So transport considerations, the AHA basically tells us if we can get the patient to a PCI capable facility and within 12 hours of the onset of chest pain, do it. In our area, that's pretty feasible. There's a lot of cath labs around here. So definitive treatment for these individuals could be fibrinolysis, which is the clot-busting drugs, cath lab, or coronary artery bypass and graft, which is the bypass surgery. Okay. So, welcome back, everybody. What we're going to be talking about. All right, so, and this will make a little more sense as we move into our EKG 12 lead lecture. Hold on one second. But basically, serial EKGs are an EKG every time you do any type of intervention. In patients with decent symptoms, you're going to want to do these every 3 to 5 minutes to look for any acute changes in their 12 lead. Remember your MONA. Morphine, oxygen, nitro, and aspirin. You can't go wrong with these unless your patient's hemodynamically unstable. We don't want to be giving morphine and nitro. And rapid transport is indicated for ST elevation MIs. So, heart problems can be caused by a number of disorders affecting the condition and function of the blood vessels in the heart. We have coronary artery disease. These are conditions that narrow or block the arteries in the heart. They often result from fatty deposits building up on the endometrial, or the endothelial cells on the inner tissue of the arteries. They build up. The buildup narrows intervessel and restricts the flow of blood. So we have two different terms here: atherosclerosis and arteriosclerosis. Atherosclerosis refers to the buildup of fat, plaque, and sometimes mayonnaise in the vasculature. And then arteriosclerosis is a more general term, meaning hardening of the arteries. I hope you guys think I'm as funny as I think I am. All right. Some other terms to remember. Thrombus is an occlusive blood flow by the formation of a clot on rough inner surface of a diseased artery. Remember, we talked way back in the first lecture. Any turbulence inside the bloodstream is bad because it does increase the flow of clots, or increase the potential for clots. Thrombus can break loose and form an embolism. An emboli move freely to occlude the blood flow downstream in a smaller artery. So they can move anywhere from the heart to the lungs to the brain, and this is bad. Okay. So, reducing the blood supply to the myocardium is an emergency. Obviously this is something that needs to be addressed. Chest pain is the most common symptom of a reduced blood supply. An aneurysm is a weakened section of the blood vessel, and the blood vessel begins to dilate or balloon. They can burst, causing rapid life-threatening internal bleeding. You can also have electrical malfunctions in the heart, you guys should be quite well versed on these because we just did the last 4 or 5 lectures talking about these electrical malfunctions. Any type of malfunction in the heart's electrical system generally results in a dysrhythmia. These can include bradycardias, tachycardias, and rhythms that may be present when there is no pulse. I don't know if we talked about that, guys, but there is a rhythm that we do need to discuss that is called pulseless electrical activity. Pulseless electrical activity is generally any pulse that you see, any rhythm that you see on the cardiac monitor with no pulse associated with it. So usually a good cause of this would be trauma. You can have traumatic injuries where the patient is exsanguinated. They may have electrical activity going on, but they don't have no heartbeat because there's no blood, there's no pump. Pulseless electrical activity, you can have the prettiest looking rhythm on the world, but if they don't have a pulse associated with it, they're still in cardiac arrest. You can also have mechanical malfunction in the heart. These include angina, acute MI, and congestive heart failure. Angina is basically just chest pain caused by insufficient blood supply to the myocardium. Typically, it's going to be the result of narrowed arteries secondary to coronary artery disease. Pain usually occurs during times of increased oxygen demand, such as exertion or stress. We also have what's called Prinzmetal's angina. What Prinzmetal's is a... excuse me, guys. 1 second here. I'm trying to at least get a little comfortable. Prinzmetal angina is what otherwise known as vasospastic angina. What you have is the coronary arteries are spastic. The capillary sphincters will clamp down and constrict the arteries. So basically, you have the same effect as an occlusion, but there is none. It's just anginal pain due to spasm of the coronary artery. An acute myocardial infarction is defined as death of a portion of the myocardium due to a lack of oxygen. So anytime that you do have an MI, you do have at least some tissue death in the myocardium. Coronary artery disease is usually the underlying reason. So congestive heart failure is an inadequate pumping of the heart, often leading to excessive fluid buildup in the lungs and or the body, depending on what side of the heart is failing. So, here's a good question for you. If we have heart failure on the left side of the body, where is the blood going to back up? I'll wait. That's right. The blood's going to back up into the lungs. If we have an acute failure in the right side, it's going to back up into the body. Does that make sense? This can be a chronic or acute condition. Usually the main cause is hypertension, chronic hypertension. What happens is you have that systemic vascular resistance from the high blood pressure that your heart has to pump against, and you end up getting to a point where your muscle gets so big. You guys remember Frank Starling's mechanism? The muscle gets so big that you're unable to adequately pump because it gets floppy. And basically the simple explanation of what congestive heart failure is. It can be brought on by diseased heart valves, hypertension, and obstructive pulmonary disease, and it can often be a complication of an MI. So, talking about the progression of CHF, so your patient has an MI. They have a significant portion of the myocardium in the left ventricle that dies. Because of the damage to the ventricle, blood backs up in the pulmonary circulation and the lungs. And if untreated, left heart failure is going to cause right heart failure. Signs of CHF: tachycardia, dyspnea, cyanosis, normal or elevated blood pressure, diaphoresis, and pulmonary edema. So I'm gonna give you guys a little life lesson here, and I don't have a slide on it. I'm just gonna kind of talk through it. So if there's anybody out there that was just flashing through the slides and not listening to me talk, they're gonna miss out on this, and this is good wisdom for you. So actually, you know what? I'm gonna hold off because I believe I have a slide that talks about it later. So our signs and symptoms of CHF: we can have anxiety, confusion due to the hypoxia, pedal edema, engorged or pulsating neck veins, and enlarged liver or spleen. Here we have our poor lady with CHF here. Okay, so this is what I was getting ready to talk about a minute ago. A little case study for you guys. We get called to a patient that is having difficulty breathing. They have a history of congestive heart failure and COPD. He's 70 years old. Complains of difficulty breathing, history of high blood pressure, COPD, CH, diabetes, etc. So you listen to his lungs. You hear diffuse wheezes and you hear wet. So how do we know what to do? This is an age-old question. You can find a lot of information out about it on the internet. And here's the problem, guys. When we get to this point, we have to determine if their problem is COPD related or CHF related. A lot of these COPDers, they have chronic pneumonia, so it's not uncommon to have, at least some fluid in their lungs. So what we need to be able to determine, is this an acute onset of pulmonary edema with the lungs filling up with fluid, or is this simple exacerbation of COPD? There is some ways that we are able to determine which one's which. Here's some important things to remember. People with flash pulmonary edema can still wheeze. We can hear cardiac wheezes from the friction of the fluid in the alveoli. People with flash pulmonary edema usually have a very acute onset. All of a sudden, it starts. Whereas COPD exacerbation is usually increasing in severity over a period of hours or days even. People with flash pulmonary edema also have marked hypertension. It's not uncommon to see blood pressures over 200, 220, 240 systolic. So anytime you see a blood pressure that high with a difficulty breather, you need to be considering left ventricular dysfunction and acute pulmonary edema. People with pulmonary edema are usually diaphoretic and they're usually flushed. So if they have all these things, we don't want to go into the box and give them the med for wheezing if they have this. If you think about what our bronchodilators do, we carry Duoneb, we carry our, any of our beta adrenergic agonists. We get to a point where what our mechanism of action is to dilate the bronchioles, increase airflow from the lungs. So what if we do that and somebody has pulmonary edema, they have fluid in their alveoli? What we're doing is opening their bronchioles up and allowing more fluid to come in. So we don't want to do that. We need to be able to distinguish between the two. Our treatment for CHF, obviously life-threatening situations first, and patients with acute pulmonary edema are in a life-threatening situation. People cannot maintain a long bout of having fluid filled up in their lungs. So airway breathing circulation comes first. Our next step is positive pressure ventilation, or CPAP. We're going to give nitro. What this is going to do is open up our vasculature in the lungs, and providing positive pressure is going to push that fluid out. Morphine and fentanyl are going to do the same thing. Morphine is also very good for the anxiety that's associated with having fluid in your lungs. And then we're also going to treat for ACS if it's indicated. So, hypertensive crisis. Depending on where you work at, hypertensive emergency is defined as a symptomatic patient with a blood pressure elevated 210 over 110 millimeters of mercury or higher. So we obviously have some risks with these patients, namely being aneurysm of the pretty much anything, aneurysm of the aorta, the thoracic aorta, also the brain. We can have CVAs from this, from having a high blood pressure sustained over long periods of time. So we should obviously be concerned for bleeding, stroke throughout the body, stroke and bleeding throughout the body, rather, aneurysms. Our symptoms of this generally going to be dizziness, headaches, blurred vision, ringing in the ears, or tinnitus, nosebleeds, stuff like that. Nosebleeds without cause. You need to be on the eye. That blood pressure. Okay, so the treatment for this in the field, depending on your local protocol, ultimately the cause needs to be determined, but in the emergent situation, that pressure needs to be treated. So, speaking of the cause, consider something such as autonomic dysreflexia. Basically, autonomic dysreflexia is common in paraplegic patients. They're unable to feel pain, depending on, paraplegic, quadriplegic. It depends on where it's at. They're unable to feel pain, but they still have pain receptors. Those pain receptors are still activated. They're just not getting the signal back to the brain. So they still have all the motor neurons and sensory neurons present, but they just can't feel. So you have all these sensory neurons, say that they're in pain for whatever reason, and you have these sensory neurons shoot to the brain saying, this hurts, we need to do something, we need to fix this. And nothing happens for hours and hours. Over time, what happens whenever you have an acute sharp pain? Your pulse spikes, your blood pressure spikes. So imagine this going on for a period of hours and hours and not realizing it. So this can cause extremely high blood pressures. And in the end, we can give all the medication we want, but the treatment is to fix the cause. For example, the specific case I'm referring to, the gentleman had his belt on too tight. He didn't realize it. His belt was so tight, it was cutting off circulation to his lower extremities. But he didn't know it. So he was in pain. He just didn't realize it. And he was getting those messengers up to his brain saying, this hurts. And so his blood pressure was skyrocketed. High blood pressure. And that was the treatment for it, was to loosen his belt. Another episode, wearing shoes that were too small. Didn't realize it. Feet are in pain all day. You don't realize it because you're paralyzed and your blood pressure is elevated from that. So, aside from autonomic dysreflexia, there is some treatments that we can give for acutely high blood pressure. Generally, our first line is going to be a nitro, 0.4 milligrams sublingual. We can also, first generation beta blockers are common. Labetalol would probably be the most common one. See some places that started carrying Cardine as well, a calcium channel blocker for this. Depending on where you work, acutely high blood pressure should not be lowered more than, depending on where you work, it can be 20%. So you want either the top, you're going to treat until the top number or the bottom number decreases by 20%. So if your bottom number is 120, say your blood pressure is 240 over 120, you're only going to want to lower that top number down to 192. So still pretty high. But we don't want to drop that blood pressure down to 120 over 80 due to the fact that this is going to create a rebound hypotension. It takes, your body takes time to adjust. It took time to adjust to having that high blood pressure. It takes time to adjust to getting it back down. So all your vasculature just had a big, dilation. And so you have all this fluid that's just rushing down to your legs by gravity. And the body doesn't know what to do. So you can create a relative hypotension, even though we're dropping it down to 120 over 80, and your patient's unresponsive and you can't figure out why. So usually 20% is the rule of thumb to lower it using those medications. Pericardial tamponade. You guys remember way back in lecture 1, we talked about that pericardial sac. There is fluid in there normally. If you have too much fluid, this can inhibit the pumping action of the heart. I had to put this quote in there. I saw it on TV. I don't remember what the show was called, but it was pretty funny. We don't have 2 minutes. I have to evacuate the blood. So that is the treatment. You do have to evacuate the fluid. We don't. But somebody has to evacuate the fluid out of the pericardial sac to release this tension and allow the heart to resume its pumping mechanism. Causes of pericardial tamponade, trauma, infection. It's pretty rare. I've run into it a couple of times. The patient knew that they had it and they were going for treatment for it. The treatment is a pericardial centesis. They take a long syringe with a needle. They take a electrical, basically it's an electrical wire. They have the patient on a cardiac monitor. So this needle has an electrical stimulus going through it. Go in under the sternum, through the diaphragm into the pericardial key. They insert the needle until it hits the left ventricle. They know it hits the left ventricle because they see a bunch of electrical activity on the monitor because they have an energized needle. They back it out slightly and then you eject the fluid. And that's pretty much all there is to it. Beck's triad is the indications of pericardial tamponade. A narrowing pulse pressure. So as your initial blood pressure is 150 over 90, and you say 140 over 100, and then 130 over 110, that would be your narrowing pulse pressure. Your muffled heart tones due to the fact that there's fluid in the cavity around the heart that's not supposed to be there. And jugular vein distension due to the poor cardiac output. You're also going to see signs of cardiogenic shock. You can see pulseless electrical activity, pulsus paradoxus, and alternans. Pulsus paradoxus is a pulse that is stronger in one side than the other. And electrical alternans, I think we've already just discussed what that was. I do have another example of it. On the next slide here. You have to forgive me, I just lied to you on what pulsus paradoxus was. Pulsus paradoxus is actually a transient drop in the blood pressure on inspiration, greater than 10 millimeters of mercury. Here's an example of electrical alternans. You guys remember you have your small complex, large complex, small complex, large complex, etc. Okay, we're going to talk about cardiac arrest now. This is going to be a pretty good review for you guys. AEMTs can pretty much give all the cardiovascular drugs in cardiac arrest. I believe the only other med that I haven't covered that you guys can give is morphine, I believe, for chest pain. Per the state, depending on where you work, it could be different. Morphine is a narcotic, opioid analgesic. Usually the dose is 2 to 10 milligrams IV slow push. And we'll talk about that more later. I'll get a slide in and we'll discuss morphine. But first we're going to talk about cardiac arrest. Chain of survival, stuff you guys learn in EMT school, all right, from the American Heart Association. Number 1 is immediate recognition and activation of 911. Number 2 is early CPR, early defibrillation, effective advanced life support, that's you guys, and integrated post-cardiac arrest care, that's the ICU. So, prompt notification of the EMS system is truly the number 1 indicator of increased survivability in cardiac arrest. Most likely going to be a responsibility. We can't really call ourselves. Early CPR. This is our dispatcher's job. Pretty much anywhere you work now, when a cardiac arrest is phoned in, they're going to give pre-arrival CPR instructions. Other ways that we can help with that, we can get CPR trained professionals to the patient faster. First responders, we can train lay people in CPR, and train dispatchers to instruct callers how to perform CPR, which is being done most places around here. Early defibrillation. The sooner the defibrillator arrives, the more likely the patient's going to... All right. Effective ALS. Very important. Maintaining airway, ALS airway, correct medications, correct treatments, and rapid transport to the hospital is going to be the most effective way of ensuring high survivability. And then post-cardiac arrest care, there's a lot of stuff that these guys go through once they get to the hospital. Most of them end up getting a heart cath, therapeutic hypothermia. There's a lot of stuff that are going to be that's going to be done. Including this stuff right here. So maintenance or management of cardiac arrest. So not just EMTs, all of us are responsible for performing early CPR, rapid defibrillation as soon as we get on scene when it's indicated. We're going to provide ALS. That's what you guys are doing. Artificial ventilations and airway management. Interviewing bystanders and getting a history, moving patients as needed. Not really going to talk about AEDs because you guys can determine if a rhythm needs shocked or not. We'll talk about the types of shocks. Monophasic defibrillators are not used anymore. They send a single shock from the negative pad to the positive pad. Biphasic shock sends a shock in one direction and then back to the other one. That's why you see these days a lot of the patches don't say that they have to go on the chest and the side. They can go either way because the shock travels through both of them. You guys know how AEDs work. I'm not going to go through a bunch of this stuff, guys. You should all be familiar with this. It is important when we're checking our heart rhythm on our cardiac monitor that we do not interrupt CPR for more than 10 seconds. You guys know about CPR. Need to be compressions hard and fast in the center of the chest, at least 2 inches deep, allowing full recoil. At least 100 per minute. Rotate personnel as needed. Post-resuscitation care, manage your airway. Avoid hyperventilation. Keep the cardiac monitor on somebody because they can go back into cardiac arrest. Reassess frequently. Consider hypothermia. So basically, if you guys aren't familiar with the therapeutic hypothermia, what this is, providing or cooling the patient to a cooler than normal temperature. I think it's around 34 degrees Celsius by giving chilled saline, cold packs on the body. Basically puts the heart and brain into hibernation to prevent injury, long-term injury. And there's some compelling evidence showing that it does provide some pretty good benefits. So if a patient does go back into cardiac arrest while we're driving to the hospital, you need to resume CPR, analyze the rhythm, shock it as indicated. Depending on where you work, they may have a mechanical CPR device such as the auto pulse. Thumper's a little outdated. The LifePak Physio Control has the Lucas device. So I know I fast forwarded through a bunch of those slides. Nothing that we really haven't covered already. You guys should be well versed in rhythm interpretation, so we're not going to spend a lot of time talking about AEDs. because you're going to be using a cardiac monitor, interpreting the rhythm and determining if the patient needs shocked or not. Our two rhythms that we are going to provide shocks on are pulseless V-tach and ventricular fibrillation. So there are a lot of presentations that somebody can have when they're having acute coronary syndrome. They may have pressure or pain in the chest with difficulty breathing. Others may just have mild discomfort that they ignore. Between 10 and 20% of heart attack patients deny chest discomfort. So there is a lot of different presentations they can have. There's a lot of different possibilities and complications of heart problems. So we need to always have a high suspicion and treat patients with these symptoms for cardiac causes. ACS patients need high flow O2. They need to be treated per our local protocols, and they need to be transported to the appropriate destinations. I don't know. I guess this is just like an EMT basic thing. I use this. I don't remember it being this dumbed down, though. You guys don't need to assist patients who have their own nitro. You can give the nitro that we have on the ambulance. To provide maximum survival and cardiac arrest, we need to strengthen our chain of survival. You guys know the heart is a simple pump. Moves deoxygenated blood to the lungs and oxygenated blood to the body. Pressure within the cardiovascular system is very critical to the moving of the blood. Remember that acute coronary syndrome is a blanket term. It can mean a lot of different things. Oxygen, nitro, aspirin, morphine are the key medications indicated to treat ACS, and transportation to the appropriate facility. Most cardiac conditions are caused by arterial problems. Angina and acute MI are caused by inadequate perfusion of the heart. Heart failure can be caused by either electrical or mechanical problems. High quality CPR is the number one indication of survival to out of hospital. Remember that we are going to shock VFib and VTAC, and we'll talk about that in detail later. And we're not going to go through these questions. So we already discussed therapeutic hypothermia, and we'll talk about our ALS guidelines and algorithms in the next lecture. This is a conclusion. We have a question here at the end. A 78-year-old male complaining of severe shortness of breath for 20 minutes prior to your arrival. When you arrive, you find the patient unconscious and not moving. What are your immediate priorities? Okay, go ahead and proceed to the quiz, guys. This is the conclusion. Sorry that this lecture was a little bit dumbed down. It is a good review, though. Whenever we come back, we're going to start talking about our ACLS stuff and the meds that you guys are going to be giving in these scenarios. So prepare for that. We'll talk about synchronized cardioversion and defibrillation and our cardiac meds in a little more depth.